the last one. We're gonna get you through this. You don't have to remember that many things by the end of this, so stay awake. So, if you can't stay awake, you can raise your hand and say, I'd like to play with a balloon. And then you can play with a balloon. And then, but please don't check your Facebook. Okay. So, people like to say that babies are scared, right? And that they're scared when babies are really sick. And I don't think you're wrong for feeling that way, and I don't want to disabuse you of the concept of being afraid of a baby when they're sick. But I want you to be afraid of a baby when they're sick for educated reasons that make you know why it's going to be hard to solve this question, not because they're little. Because like, they're just people. They're people like the old people. Who cares? The little tiny ones aren't even all that cute, so don't give me that excuse. So we're gonna try and change the concept of why to be afraid. Like, let's be evidence-based afraid, right? Okay. So you think of obstruction, right? And you think of bilious vomit, and you think of like absolute constipation or not passing flatus, which like maybe people are paying attention to flatus with babies. They make a little tube for putting it in babies' butts and taking the farts out, which is ridiculous. So people are paying attention. But we also think with babies about meconium delay. Meconium delay, please ask about meconium. We think about bloody stools, and as anybody who was in the ED last night knows, that that's a late finding that we don't really want to get to that presentation. And we think about distension. So, it's fair for you to feel nervous about obstructed neonates because they may look like they're having non-bilious vomiting. They may have totally normal passage of meconium. Please, I hope that they're not having bloody stools because that's late. We hope everyone. And they may have a flat, non-distended abdomen. So don't be afraid because you don't know what's going on. Know that like, okay, wait, I'm going to start considering that this could be why the kid is there. And I'm one thought process ahead in how I'm examining this kid. So babies are all about atypical presentations and they don't talk. So, I hate the thing where like, here's the case. Let's give it pretty simple. Baby comes in the first week of life, there's been bilious vomiting, they don't look that awful. They're moving, they look a little dry, they look a little thin, they haven't had their repeat check, okay? So, you're gonna take a history and a physical and do a physical exam on this kid. You're going to get IV access if you're really truly worried, and you're going to do this with gradual hydration because renal, take home point number 1, renal concentrating capacity does not start until 9 months. So whenever sepsis is around, we're really worried with kids about how they're going to be absorbing fluids, but if your kidneys haven't learned how to regulate that stuff, then please be extra careful about that, okay? We're going to start with an x-ray, because we're going to start with an x-ray, and we're going to try and figure out right away if we're looking at a lower obstruction or upper obstruction, and look for air. I don't have to tell you guys what pneumatosis looks like, I don't have to tell you what free air looks like. You know that that's all the same. And then we're going to place an NG. So, why would audience participation, really, anybody want to shout out why a baby in the first week of life with bilious vomiting who you're worried is obstructed, might have a flat abdomen? There are no dumb guesses. And anyone who guesses gets a balloon. Why might you have a flat abdomen? What makes an abdomen big? Gas. Great. So if you're in your first week of life and your abdomen, first like maybe 4 days, and your abdomen is flat, what's not in there? Gas, right? Gas isn't in there, okay? So if you have a kid who has an obstruction, which our first kid is going to have, and they have a flat abdomen, take home point number 2. It does not mean in a neonate that there isn't an obstruction. It may mean that they haven't been able to get any gas into the abdomen, and that's why it's small. So you see that. Yes, you're nervous, because now your big belly isn't, like you're like, oh, uh-oh. Diana's saying if I touch the belly and it's flat, that you could still be obstructed. I don't know what's going on. No, you're one step ahead because you can think about both possibilities. Scared for the right reasons. Okay? So, what is a feeding history? take home point number 3. This is a feeding history for everybody. A feeding history is not the number of dirty diapers, because we'll talk about lower obstructions later, but I don't really care how much poop there is in a kid who's got a gastro. This is a feeding history, okay? The ounces of formula, how long it takes, and if they're breastfeeding, how many minutes per breast. Whether or not there is grunting, flaring, and bobbing with feeds, and never ask a parent the words grunting, flaring, or bobbing, because they don't mean anything. They didn't mean anything to you when you were in med school. They don't mean anything to your like PhD lawyer friends. You have to do an impression of absolutely everything, right? So like, sometimes I say it's like a racehorse. You can't see, but my nose is flaring. Big Jewish nose, you can see it, right? Okay, weight gain. You can look this up. You can look this up before you present the kid, right? A kid is supposed to be back at their birth weight by 10 days of life and then be gaining about 30 grams a day thereafter for the first 2 months. So this is pretty easy to calculate. And this is something that parents aren't necessarily measuring, and you can figure out for yourself. And then you're in diapers. Again, I don't care about poop with like a gastro or somebody else. Care about poop with obstruction, obviously. But what goes out is what comes in. So like number of urine diapers. The other thing about doing that is most of what we're doing is retraining parents. So parents who come in 5 or 6 million times for gastros and keep talking about pooping need to hear 5 or 6 million times from every doctor, hold on about the poop. Tell me about the pee, because what goes in is what comes out, and babies can't go to the fridge and like pull out their own juice. Okay. We get a film. We have 2 different kids. These are 2 different patients right now. Anybody see anything that like maybe looks like double bubble? Right, so double bubble is what? Yeah, her duodenal atresia, right, okay. If the other one isn't double bubble, what is it? Don't know.
Malrotation.
Ah, yay! You get a balloon. Okay. So, we see this, we're seeing an upper obstruction, right? We're going to talk about lower obstructions another day. I would like to give you guys a lecture on all the weird stuff that meconium does, because it does a lot of weird stuff. And it's things that if you could see somebody in the first 3 days, you should know about. But we're going to talk just about those 2 x-rays right now, so that we can do a little deep dive and you can feel comfortable really understanding what's going on. And maybe have an educated conversation with a surgeon and a radiologist who you will not let run the show. You will run the show. This is your patient. Okay, so please, if you see that, place an NG tube, right? We may be nervous about placing that. If you have pH paper around, have it put when you place it so you can pull gastric aspirates and check right away. So the mnemonic for how you're figuring this all out, it is Nemo, like my favorite Pixar movie, right? So nose, ear, and then midway between the xiphoid and the umbilicus will help you get that in. Go for something small. Small will be okay. A 5 French will be okay. And it's important to think about this. So, duodenal atresia, right? These are 2 kids with duodenal atresia. The one that is, oh, I forgot my laser pointer, and I just bought a new laser pointer.
Use a balloon.
Use a balloon? Of course. Okay, so this is brilliant. Okay, so this one right here has gotten sick enough that they've presented. This is in the first week of life, right? This one has gotten sick enough that you have an aspiration that started right there. And I have to say, this one right here, Dr. Alexandra Stanislavski, she must be an actress too, Stanislavski, right? There's the actor. She didn't say this, but when you look at this on a normal screen, this one also looks like it has a pneumo. These are going to be very, very sick-looking kids. The thing about duodenal atresia is that it can be like a couple of different kind of balloons are moving. Okay. Is that it can present at different times, right? 50% of duodenal atresias you're going to know about from a prenatal ultrasound. But somebody who didn't get a prenatal ultrasound, somebody who had a home birth, or that other 50% Okay, reasons to be afraid is just knowing this stat. That it could be somebody who comes out and then goes home. But knowing that stat makes you think about it a little bit more. It makes you realize that you, when you're examining somebody in the first week of life, should examine them like nobody's ever actually examined them before. Absolutely everything, head to toe, clothes are off, femorals are felt. You've turned and actually checked that there's an anus, because I've seen that one actually get missed. And you may not have any information ahead of time that this is what you have. There are also things that look like duodenal atresia that are just other obstructions on the duodenum that I'm not going to really go into. But we're talking about duodenal web, duodenal stenosis, annular pancreasis. They can all kind of create the same appearance. The other thing for you guys to know and feel educatedly afraid about is that 1/3 of infants have this that is proximal to the insertion of the bile duct. So they're not going to have bilious vomiting. So you're not being like a worried negative Nancy if you don't have bilious vomiting but you're still worried about this and you want to get the x-ray. Get the x-ray. Be careful. Now you know, and that's okay. Half the battle, right? So what? Oh, okay. So associated with a lot of syndromic things, I'm not going to go into all the syndromic things, knowing that they're there and knowing that midline abnormalities should all be looked at midline together. So, yay, duodenal atresia, right? So then, the big reveal, this is Malro, right? So Malro we're going to see with this corkscrew-like appearance. But I want you guys to understand Malro. So Malro presents, 80% of the kids actually present within the first month. So you could have a Malro who's presenting in, I don't know, 3 weeks of life. They could have already had their first checkup. So you're the one who's going to be like more thoughtful and careful about this. Then like 30% of what remains so that they're in the first week, and the majority of them are presenting in the first like couple of days, 2 to 3 days of life. So this could be somebody who went home yesterday and then now is not doing as well and is starting to have bilious vomiting. This could be a kid who's totally normal in between, because Malro is only a problem if it's causing luminal obstruction or it's causing vascular obstruction, and everything else is just going to go through on its own. So, can I have my volunteers? Why is Malro able to present in a bunch of different ways? So, come on up. Here, we have a fetus made up of 2 lovely volunteers. We have an SMA, right? You all remember from embryology that all of that stuff leaves the body and then it undergoes all these rotations. My grandfather was a machinist, and moving parts break, right? But they don't all break predictably. So this rotation happens in 3 sections, which is why you have 3 different potential moments where it could go wrong, which is why it doesn't always present exactly the same way. So it's outside of the fetus's body and it undergoes a 90-degree rotation. This, in poo color, is the part of the embryological gut that's going to turn into large bowel. This, in gut color, is going to become the small bowel. So it comes out, it actually has this weird little diverticulum invagination that becomes the cecum, and it rotates 90 degrees. Clockwise for you. Yes, okay. So it rotates 90 degrees, and then it goes back in, and it rotates again, 90, potential for something going wrong, and it rotates again, 90. While this is happening, this section is elongating and turning into small intestines, right? So what we should have right now, if you would bring this hand down, okay, and this one up, is ascending, transverse, and descending with your cecum right here. But each time that made that rotation, that could have ended up someplace else, right? Anyone remember LADS bands? Right, LADS bands are what get us in trouble. Does anybody know what LADS bands are? Those things. But what are they? Why do they happen? Right. Why they happen helps make things make a lot more sense. Why this can all present very differently.
Isn't that, I think it secures it to the right upper quadrant and the left upper quadrant, right lower quadrant to the posterior abdominal wall. So it secures it in place.
Yes. So as we're forming mesentery, there's supposed to be fibrous tissue that keeps all of our intestine in the right place. But if instead of having, I'll take this for a second. If instead of, because we didn't rotate the right way, instead of having our cecum, small intestine, instead of having our cecum over here, it didn't rotate the right way, and it ended up mostly over here. That fibrous tissue is going to go across and attach where it can. LADS bands are like an abnormal part of development, but if your duodenum is up there, it's going to go right across it, running over like a lawnmower. So that's why that's going to obstruct that way. At the same time, you can have a Malro where basically everything colon ends up on this side and everything small intestine, this one's Malro, and everything small intestine ends up on this side, because it just stopped at that portion of rotating. And this person is not going to present for a long time because their mesentery has all this space where my head is right here to form, to hold it in place. And the LADS bands are nowhere near, like this, whatever the fibrous, they may not even be called it, whatever the fibrous tissues are nowhere near where your duodenum is. So that's why they're gonna go along for a really long time like that. So, thank you, fetuses. Okay. So if we look at that angle of trites and that black line right here as where our mesentery is supposed to form, that's supposed to be a big, wide mesentery, right? This thing has no angle for a mesentery to form. So it can twist really easily. Now, this is a somewhat G-rated version, but Dr. Iyer, who's the small gut liver guy where I did residency, explained why they twist to me in an approximation of what you see on this screen right now. This is a wide mesentery. Each fringe here is a narrow mesentery. If this girl spins, that skirt's not really gonna swish. It's gonna hold still. So this is what's protecting it from twisting off around the SMA, which I guess in this situation is actually her legs, right? Whereas this girl, all of those fringes can twist on top of one another, if that helps explain anything. So this is what I was talking about before. Malro, where everything's on one side and everything's on the other side. If you look at this one, all those little asterisks, that's large colon, right? This somebody is not gonna come to us. This somebody's gonna come to you, because this somebody, or maybe a teenager, maybe if they run a marathon. But this somebody's gonna go a really long time before somebody notices that anything is wrong. If they don't have anything else that's syndromic, or the going along with why this happens eventually. Okay, try to speed it up. So, take home point number 4, reading the upper GIs, right? So I don't know how many of you guys have you gotten enough upper GIs for little ones, for neonates? Were you concerned for this? But there's a couple of things that I want you to understand the imaging, and we'll go really fast, since I see we're a little short on the time right now. So, what you're looking for, primarily, if you learn one thing from the imaging right now, is where is our DJ junction? Where is our angle of trites? So this is a normal, and this is an abnormal. And you can take a look and see that right here, if we're looking at it like stage right, that on a normal, this angle should be on the right of the pedicles, right? This has to be done. Please advocate for your patient to have this done by an attending or a pediatric radiologist. If you look, I'm going to tell you tiny little bits about the literature for this. This is not a simple process to do. It kind of involves flipping the baby onto sides while you're doing this. And you want this to be a nice straight on image because we're looking at what side of a spine. We've all seen that x-rays are getting flipped all over the place. Please advocate for this to be done by somebody who has done this before when you're getting this study. Because in Malro, you're going to have it on this side, right? I think that looking at on the lateral is a little bit more of a fine-tuned skill, so I wouldn't really necessarily, that's a take-home point. that you should remember, because I don't know if it's realistic that I could ask myself to be able to do that. But when we look at this, we can see like all 4 sections of the duodenum looking like they are supposed to look. And here we can see sometimes it's posterior, sometimes it looks like a letter Z, sometimes it's low. This is the one that you can do on your own at home. And if you are lucky or unfortunate enough to see the corkscrew of the volvulus having formed, well, that's pretty much a slam dunk. Normal variants are like the bane of everyone's existence. So just note, this is why, another reason why you want to be advocating for this to be done by somebody who's done these before. There is an entity, which I don't believe exists in adults, but you can tell me if they do, called a wandering duodenum. It's very like Ulysses, right? So babies, they're stretchy, and their ligaments are stretchy. So let's say you have a normal attachment of your duodenum and they're vomiting, or we put in an NG tube but we didn't decompress enough, or just because they were screaming, or they have a giant spleen, the duodenum can just like slide over into the wrong place because it's not being held in with as strong tissue. So this is something that you can talk with the radiologist about if things aren't slam dunk, and make sure that they feel like they've actually rolled that out. Having it done appropriately is a way of making sure that the sequence of events was done to not get this as your false positive, because wouldn't it just be a shame if you went to surgery for a wandering duodenum? Yeah. Okay, you guys do a lot of abdominal scans. When influenza stops, I want to encourage you guys to clean that ultrasound as much as you can and bring it into the room with neonates and practice scanning their aortas, right? Practice finding their celiac trunk. Because I think is anybody with adults, done sono on your own for looking for Malro on the big people, the big ones? No. It's not actually that difficult to do. So everyone feels pretty comfortable, I'm assuming, with aortic ultrasounds. You start at your xiphoid, you scan down, you find that C-hole of the celiac trunk, and then the next thing that's shooting off after that is your SMA. Our SMA is where everything's going on with this part of the gut. So we can go ahead and take a look at that and look for a whirlpool sign. A whirlpool sign, if you have color flow on, should not be that difficult for you to see. And this is the kind of thing that if you're waiting to get a kind of stable baby in for an upper GI, and you're able to find this in the time in between, emergency medicine is about being able to use ultrasound and do things better and faster than everybody else. So that's what you're here for. So you can do it, right? And then you can really own how this kid's care is going along, particularly if anything with the upper GI is not so clear. There's some literature, I don't know if you guys use this with adults that much, but like SMA, SMV inversions. If you guys do this, please, it's not a reliable thing to use with kids. So when we look at the literature, which it's peds, part of the reason why this is all sort of loosey-goosey is that our studies have 34 kids in them, or 80 kids for our meta-analysis. But the sensitivity for this for volvulus and Malro is 28%. So if this is what you guys do when you're scanning big people that you're worried about volvulus, don't waste your time so much with looking for SMA and SMV inversions on a little one, because it's not really going to work. So just to give you guys a sense for your conversation that you're going to have with your radiologist, you've already sort of decided you're going to make sure that somebody's doing this upper GI in a way that they know how to do it, and if it's a resident, that they're having it supervised with an attending, because weird stuff goes wrong with weird little squishy babies, and you want someone who's done it before. You can go and look for that whirlpool sign when you find your SMA on that little baby, but you got to practice this summer when things aren't that bad, looking for SMAs and celiac trunks and little babies, and you can do that fine. You don't have to use the SMA and SMV inversions that you guys wouldn't frequently think about with adult patients or with teenage patients and things like that. And put it all together. Those aren't amazing sensitivities. I've already told you now that the belly shouldn't necessarily be big. The duodenum might move on its own entirely. The vomit might not be bilious. And these aren't spectacular sensitivities for your test. I understand why we might go back to that scary green zombie baby at the beginning and be like, well, now I don't have an algorithm and I don't know what to do and I can't hang my hat or anything. But you know percentages here. You have a sense of all the other things that can go wrong. You are informed and scared, but not uninformed and scared. And you can put all these things together pretty easily. So just to review, the number one thing that, if you guys aren't doing this now, you're taking a look at it, you can do this side. This side is not that hard to do. This side's pretty easy to Google. It's pretty easy to like look at a bunch of images, and it's pretty easy to just be like, my duodenum's on the right of my spine, my duodenum's on the left of my spine. And that is like your number one take-home point for when you're seeing these kids. So please take a history of meconium passage in food. Please put it in an NG and an IV. Hydrate them carefully. And then don't anchor on your imaging. And if surgery wants to anchor on their imaging, have a conversation with them about whether or not they want to combine ultrasound, whether or not, and also the upper GI together, and whether or not they feel like the study that they got was the best possible study, because it's worth it. And then the final thing is that you guys can practice with every baby. Practice the same, it's the same aorta, so you guys can do that all at home. Of note, if you're allergic to latex, those are all latex balloons, and I'm allergic to latex. And I only found that out after I tried to blow one of them up, which is not so good. So here are all my references if you want to take a look at any of the evidence for how we're doing that. But I have to give big thanks to my super, who gave me the air compressor to help blow up all of the balloons today. Question? Okay. If you want a balloon, please take a balloon. I'm not touching them anymore.